Hello Medicos, in this video I am going to explain Marfan syndrome. In my previous video I have explained autosomal dominant, autosomal recessive and X-linked disorder and their pattern of inheritance as well. Now this is the first example of autosomal dominant disorder. It can be familial as well as it can be due to new mutations. New mutations are those which occur during gametogenesis and familial are those which are present in parents and they are transferred to their new ones. This is a disorder of connective tissue. In this skeletal system, eyes and CVS are involved. Now let's see how Marfan syndrome occurs in our body and where is the defect. So there is a glycoprotein in our extracellular matrix, that is fibrillin 1. Fibrillin 1 is defective in this case. Now first of all we have to see what is the function of fibrillin 1 and how it causes Marfan syndrome. This fibrillin 1, this provides support to our skeletal system. It is abundant in our skeleton, in our eyes, in our CVS system, and it provides support. Now if this fibrillin 1 is defective or less fibrillin, then there will be the loss of structural support. It is present in elastic structures as well as in non-elastic structures. In elastic structures, it provides scaffolding for tropoelastin. Now, the tropoelastin will come and join with this fibrillin and will provide elasticity there. And we know our elastic tissues involve skin, filaments, arterial walls, and non-elastic structures include tendons. In both of these tissues, it provides support, and that's why its deficiency causes loss of structural support in our extracellular matrix. These fibrillins are abundant in eyes, aorta and ligaments. That's why it mainly affects our eyes, cardiovascular system and skeletal system. Now this fibrillin has two homologous forms, fibrillin 1 and fibrillin 2. Fibrillin 1 is present here and fibrillin 2 is present here. Now how to study this sequence? The first number indicates the number of chromosome. Second, Q or P. Q indicates the long arm of the chromosome, while if here is P, then it indicates the short arm of the chromosome. And next thing is the position of locus or position of gene. So fibrillin 1 is encoded by chromosome number 15 and its gene is present at 21.1 position at long arm of chromosome number 15, and same fibrillin 2 is present on our chromosome number 5 on its long arm at position 23.31. Now in Marfan syndrome there is involvement of fibrillin 1. So basically this structure is mutated in Marfan syndrome that can lead to Marfan syndrome. It inhibits the polymerization of fibrillin fibers that will lead to the loss of structural support to our extracellular matrix, and that's how it causes the Marfan syndrome. Now its homologous form, that is fibrillin 2 encoded by this chromosome, this gene, causes the structural arachnodactyly. What is structural arachnodactyly? It is a skeletal muscle abnormality, but this is not included in Marfan syndrome because in Marfan syndrome there is basically the mutation of fibrillin 1 which can lead to the loss or defective fibrillin 1 in our body. Now this is the first thing, that's how fibrillin 1 causes the Marfan syndrome. Second function of fibrillin 1 is it inhibits the excessive activation of tissue growth factor beta. This tissue growth factor beta, if present in excess, it can increase the activity of metalloproteases, and these metalloproteases will cause the loss of extracellular matrix. Now, due to loss of extracellular matrix, it can have deleterious effects on vascular smooth muscle development. So, this fibrillin 1, if present in its normal form and its normal amount, then it help this structural support to our extracellular matrix, and as well as it provides inhibition of this tissue growth factor beta. This was the function of fibrillin, and if this fibrillin is defective or less amount in our body, then it can lead to the Marfan syndrome. Now let's see what clinical features. There are great variations in clinical features. First of all, there can be floppy valve. The floppy valves are due to loss of connective tissue in mitral valve, which can make these valves soft, and that are floppy valves. And we can see the floppy valves through this echocardiography. Second thing, we can access the clinical features through our set criteria, that is devised Kent criteria. In this, we usually take the family history. That if there is a family history of Marfan syndrome, then there is possibility that the presented patient is also of Marfan syndrome. And second thing we see is the mutation of fibrillin 1 is present or absent. So we have to see this mutation. Third thing, we see cardinal signs if there is absence of family history. And fourth thing, if we see the major involvement of two systems like skeletal system, ocular system, CVS system, skin. So if there is major involvement of two systems, then we can say that this is a Marfan syndrome. What is morphology? What is the morphology of patient with Marfan syndrome? There is skeletal abnormality, there can be ocular changes, there can be CVS lesions. If we see the skeletal abnormalities, then the patient will be tall and have long extremities, long arms and legs, long tapering fingers and toes. Second thing, the patient is having this dolichocephalic head shape, like dolichocephalic head. What is dolichocephalic head? It is that the head is having frontal eminence, more frontal eminence and prominent supraorbital ridges. Second thing is kyphosis. This is the bending of our spine. And another thing is pectus excavatum or canavatum. Like there can be pigeon chest as well as there can be depressed sternum. This is pectus depressed due to depressed sternum. This is pectus excavatum, and pectus carinatum is pigeon chest. Now, the other thing can come here is thumb hyperextensibility, like the thumb can touch back to the wrist. So these are the skeletal abnormalities that are found in Marfan syndrome. Second thing is ocular changes. In ocular changes, we can see the ectopia lentis. If the patient is having bilateral subluxation or dislocation of lens, then this is called as ectopia lentis, and this ectopia lentis is very common in Marfan syndrome. Like it is less common in other syndromes, so we can suspect if a patient with ectopia lentis that he must be or he can be the patient of Marfan syndrome. Other thing comes here is CVS lesions. In CVS lesion, what happens? There is loss of medial support to aorta, and there is excessive tissue growth factor beta signaling. Both of these things causes the loss of extracellular matrix, which can lead to the dilation of aortic valve, and that can lead to the aortic incompetence. Due to loss of this medial support and tissue growth factor beta signaling, there can be aortic aneurysm and aortic dissection, which can lead to the tearing of our intima and media, and this can lead to the aortic dissection. There is no any treatment for Marfan syndrome, but we can manage Marfan syndrome. Like we can give beta blockers. What is the function of beta blockers? Beta blockers will help lowering our aortic valve stress as well as heart rate. So that's why we give beta blockers, because this floppy valve clinical feature or these CVS lesions can be fatal in Marfan syndrome. So we usually give beta blockers. Second thing we give is the blockade of angiotensin II receptor. Like we can give losartan, candesartan, etc. So